Okay, welcome everybody. So first of all, I'd like to acknowledge that we're meeting here and our institute is housed on land that is traditionally owned and cared for by the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past and present and any other Aboriginal elders that are here today in the institute or in the Parkville precinct. So we are very fortunate today, and I'm delighted to introduce Professor David Amor. So David did his training in paediatrics and genetics at the RCH before doing his PhD in chromosome biology at MCRI. In 2016, he was appointed as the Galley Chair in developmental medicine at the University of Melbourne, and before that, he was the Director for the Victorian Clinical Genetics Service. His current research focuses on the genetics of intellectual disability and translating the new genomic technologies into clinical practice for the identification of genes in rare syndromes. So welcome, David. We're very much looking forward to your talk.
Thank you very much, Marnie, and I'm very pleased to be here. It's a great pleasure and honour. What I'm going to talk about today is a project that we've been running over the last 2 years and is now getting towards its end point, or at least we're at that point of submitting manuscripts and so forth. And this is part of the Melbourne Genomics Health Alliance, one of the flagships, which is the Congenital Deafness flagship. The talk really is in two parts. So at a research level, there are two components. The first is trying to identify causes for deafness, and the second is the title in white, which is how we used the information we got to provide a model, at least conceptually, for implementing genomics into newborn screening. So I think a lot of you will be familiar with the Melbourne Genomics Health Alliance, the WEHI being a partner along with RCH, MCRI and various others, and this has now been running for a number of years. And the purpose has really been to implement genomic technologies, and particularly whole exome sequencing, into clinical practice. Before this project started, I think it's fair to say that Melbourne had become a bit of a backwater on the international scene in terms of clinical implementation of genomics, and we used to look at other parts of the world, particularly Europe and the US, at the things that they were doing and feel that we were well behind. But I think it's fair to say that the Melbourne Genomics Project has really given us a kickstart, and we are now equal to any in the world, and in some instances better. So just a brief overview of the Melbourne Genomics flagships, and we are my flagship, or the flagship I've been leading, is the Congenital Deafness flagship. It was part of the second phase of Melbourne Genomics, and it, strictly speaking, ran from 2016 to 2018. Whoops. So why did we choose deafness to run a flagship? Well, for a few reasons. One, it's a common health problem and certainly affects a large number of individuals later in life. But in terms of relatively severe congenital deafness, affects about 1 in 1,000 newborns and is known to be genetic in at least half of cases. So the current conventional view is that probably about half of all deafness, congenital deafness, is known to be genetic. About a quarter is known to be non-genetic, that is environmental, and things like viral infection being a principal cause. And then there's about a quarter that is unknown. And of course, that may, in the fullness of time, be demonstrated to be genetic as well. One of the particular advantages of studying congenital deafness is that for the last decade or so, we have had newborn screening in Victoria for deafness. So anyone who's had a baby in recent times will recognise this picture over here of, so this is a babe, this is actually Lil Downey, who's my PhD student's baby. So she actually had a baby born into the project. Fortunately, was not deaf, so she did not have to enrol her own child into the project. But this is a babe having newborn hearing screening, which is typically done, before the child leaves hospital. And this is the initial screen. If that screen's positive, the babe will go on and have formal audiology assessment. So one of our ideas was that we have existing newborn screening. We had an opportunity to ascertain severely deaf infants at a population basis. And this was distinct from the other Melbourne Genomics flagships, which have typically recruited in an ad hoc or clinic-based fashion. We had the opportunity to try and ascertain basically every baby that was born in the state over a period of time. Now, prior to us starting the program, our available or funded, I should say, clinical testing for deafness was fairly limited and pretty much meant clinical assessment, or whoops, I'm going to get better at this soon, clinical assessment and testing for these two genes, or essentially the same locus, which is the connexin 26 locus. So connexin 26 has been recognised for many years to be the most common or most important cause of autosomal recessive deafness. But essentially that was the only test that we had funded by the government and routinely available. And we hoped to improve our diagnostic rate to 50% or above. So we set out to do a prospective study of a birth cohort, which was basically every baby that was born in the calendar years 2017 and 2018. And we elected to include babies that had bilateral hearing loss, so we excluded those that were unilateral, and the hearing loss had to be at least of moderate severity. So we excluded babies, we excluded the mild and moderate, and basically we were looking at the moderately severe, severe and profound, corresponding to the hearing loss of in excess of 40 decibels. Now, when we set out, we knew that Victoria has about 75,000 babes born each year, and so we estimated that based on a 1 in 1,000 prevalence of severe deafness, we would have approximately 150 eligible infants for recruitment. And we didn't really have any idea how many we would be able to recruit, but we estimated 80%, which would have corresponded to about 120. So the Melbourne Genomics project is pretty much an exome-based project, but for deafness, we selected a panel of 143 deafness genes. So basically we scoured the literature, existing diagnostic panels, research, and we came up with 143 genes that we thought were bona fide deafness genes. In fact, as time has gone on and we've spent quite a lot of time curating variants in these genes, it has become evident that in fact quite a few of these genes have fairly provisional or inconclusive evidence for causation. And also some of them have turned out to be quite polymorphic to the extent where we may have regretted putting them on our list. But for what it's worth, we had 143 genes on our deafness list. We also ran SNP array on all of our patients based on the fact that copy number variation is important for some deafness, particularly recessive deafness. Now, we were fairly lucky in terms of our recruitment that, as I mentioned, there is a Victorian newborn screening program for deafness, so we were able to access patients directly from that. We also have integrated infant hearing loss clinics based both at RCH and at Monash. And there is a project called VicChild, which is a large prospective study which basically collects data on newborns who are detected with deafness from the Victorian Infant Hearing Screening Program. So we basically got all of these people together and were able to sort of integrate our data collection so that people, so that patients didn't need to consent and provide information on multiple occasions. So, so how did we go with recruitment? Well, this is one of these typical flowcharts which has quite a lot of data in it, but the main message is that we ended up with 156 patients who were eligible and contactable. So that was pretty much what the number we had predicted, and we had 68% of them consented to the program. So 68%, that was a little bit less than the 80% we had predicted. An important question is why patients would have declined, and we did collect various, or we asked patients how they, why they had declined, and this is just a summary of the information they provided. So some just said they weren't interested. Some they said they already had a genetic diagnosis before we got to them. Some just felt it wasn't the right time for them, or some of them felt that they had evidence that it wasn't genetic, or they didn't believe the problem was genetic. There was a few patients raised the issue of insurance, which is something that comes up occasionally in genetic research, and then some other things like just not wanting to have blood taken. Oh, did I do that? I didn't touch anything. Oh, yeah. It's not on my screen, so... Oh. Okay, so the results of the exome testing. So this is just a summary slide which shows what we found. And so just starting with the connexin 26 gene, you can see that we found 21% of our cohort had causative variants in that gene, so that was about what we had expected. We found 15% had causative variants in other non-syndromic deafness genes. There was about 20% had a diagnosis of syndromic forms of deafness, or syndromes that have had deafness as a part. We were also testing for cytomegalovirus infection, and we had 4% confirmed CMV infection. And therefore, overall, we had 40% of patients remaining who didn't have an identifiable cause. So we had an overall diagnostic yield then of 56%, so fairly close to what we had anticipated based on the literature. In terms of the inheritance, the vast majority of genetic deafness was autosomal recessive. There was a small amount that was autosomal dominant, and we did not see any X-linked deafness. Of the autosomal dominant cases of deafness, the majority were de novo mutations. That is, when we tested the parents, they did not have the variant, but there was a small proportion where the variant was inherited, and in all of those cases, the parent was known to have deafness, so there was a priori evidence of a genetic cause for their deafness. In terms of the severity of the deafness, our pickup rate was the greatest in those with severe or profound deafness, sitting at around 70%, and it was a bit lower in moderate deafness. And I guess we have an expectation that as the deafness becomes less severe, probably the proportion that is accounted for by monogenic causes will decrease. So I'm just going to give you a few case reports just to kind of give you a bit of a flavour for how the work panned out in the clinic. So this is the first one. This is baby Fern, was born at 41 weeks following a normal pregnancy. Was referred for formal audiology assessment after failing a screen, and the audiology showed profound bilateral sensorineural hearing loss. Fern was then referred to the cochlear implant clinic, which is the standard course, had a normal brain MRI, and I'll talk a little bit more about Usher syndrome later, but Usher syndrome is a form of recessive deafness that also has retinal abnormalities associated with it. So basically these children are born deaf and then they end up going blind or becoming blind when they are older childhood, in older childhood. And it's an interesting concept, I guess, in now the internet age and the age of internet communications. We find that a lot of our parents are quite concerned about Usher syndrome. So, 15 years ago, patients would never come to you saying, has my patient got Usher syndrome? But now within the community of families where they have a deaf child, there's an anxiety about Usher syndrome. And that was the case with this baby. So the parents are saying, well, is my child going to go blind as well? So certainly a very valid concern from a parent perspective. So the exome sequencing in this patient revealed compound heterozygous variants in this gene, MYO15A, which were assessed as pathogenic. So this is a non-syndromic form of deafness. The parents were able to be reassured firstly, that their child would not go blind, that they didn't have Usher syndrome, but also this particular gene has no other syndromal association. So we can confidently say deafness is the only health problem we expect your child to have, and they were very grateful and reassured for that information. So this is just a summary of the genes associated with non-syndromic deafness that we found. I guess the key point here is that whilst we have the GJB2 or connexin gene at the top being by far the most important, nearly all of the others are small single figures, so there's no sort of obvious second in line after GJB2. Implications of these findings, as I said, relief, don't need further screening, and some of our patients will choose to utilise this information for reproductive purposes. So that means most commonly, the most common pathway would be that they use IVF and pre-implantation genetic testing, or PGT, to exclude embryos that are affected by the disorder. So another case, similar story, baby Sienna, was reviewed at 4 months of age following a diagnosis of moderate to severe deafness. Mum felt a lot of guilt because she had had an illness at 28 weeks, had taken antibiotics, was concerned that the antibiotics were the explanation for the deafness. I guess when you work with parents who have a child with any congenital abnormality, often they analyse what happened in the pregnancy and look for some possible explanation there. In this case, there were variants detected in this gene SLC26A4, which causes a disorder called Pendred syndrome. This is a syndromic form of deafness. It has implications because when the children reach adolescence or older, they're at risk of thyroid disease, hypothyroidism, and there's also a risk with head trauma that can make the deafness worse with this condition. So based on this information, we were able to provide advice about the longitudinal management of this child. Once again, the parents were relatively relieved that there was not something more serious going on. Of course, it's not always good news. Baby Eliza, we did not see till age 1 year of age. Sometimes it took a little bit of time for the babes to come through to the clinic. And we kind of had a hunch that Eliza had a genetic cause of deafness because she had a 3-year-old sibling who also had deafness, of course, hadn't been in the age cohort for our project. And so Eliza was recruited, and she has pathogenic variants in one of the Usher syndrome genes, Usher2A. And so this is Usher syndrome, obviously very disappointing for the parents, creates a lot of concern and anxiety, but we're able to put them in contact with the Usher support group, which is featured here, and they're quite proactively looking at novel treatments, and which include things like stem cell therapy, and also simpler things like supplementation with vitamin A, where there's some evidence that may decrease the risk of retinal damage as they get older. Of course, we were also able to confirm that diagnosis in the older siblings, so this couple now have two children who have Usher syndrome diagnosed. So if we look at our deafness syndromes overall, we had a bit of a mixed bag of syndromes, but obviously Pendred syndrome, Usher syndrome, a few other interesting disorders. We found one patient with a de novo variant in the GATA3 gene. This causes a syndrome of hypoparathyroidism, deafness and renal dysplasia. And so we know in this child that they, as they get older, we need to look out for hypoparathyroidism. We did do a renal ultrasound and that was normal. Waardenburg syndrome, and at the bottom Stickler syndrome, which is a disorder where there's risk of retinal detachment. So once we make that diagnosis, we can provide prospective advice about treatment, and these kids often they get treated by ophthalmologists and get some laser therapy to make sure they don't get retinal detachment. we also made some diagnoses of syndromes that we didn't necessarily think of as deafness syndromes, and I guess that reflects how we ascertained our patients, because we were basically picking up every child who had severe deafness at birth. And this is baby Fatima. She'd been born at 24 weeks gestation. She had lots of complications, which were initially assumed to be related to her prematurity. Babes born at 24 weeks tend to have a stormy and difficult course. And she did have bilateral hearing loss, but she also had cataracts and microcephaly, and she was slow to develop. And on her exome, we found a homozygous variant in the gene ERCC6, which causes a disorder called Cocaine syndrome, which is a progeroid premature ageing disorder. So this is a very bad diagnosis to have. These children tend to die in childhood, but at least we were able to make that diagnosis earlier than it would have been made if she hadn't been part of our program. And there was a number of other syndrome diagnoses that we made. Cornelia de Lange syndrome, a disorder associated with hemolytic anemia, Charge syndrome, Noonan syndrome, various others. So we put together all of that information because we're trying to kind of work out, is this something that's worth doing? And so one of the things that we looked at was what are the clinical implications of obtaining genetic diagnoses in these patients? So we were able to summarise that 36% of our patients received a non-syndromic diagnosis, so they could be discharged from regular care. 9% needed a specific screening program or specific protocol for care based on their genetic diagnosis. 2% had a specific treatment offered based on their genetic findings. 4% had a complex neurodevelopmental syndrome that informed medical care. And in all of the patients who received a genetic diagnosis, we were able to give them accurate reproductive advice. In some cases, that was that there was a 1 in 4 risk of recurrence in future pregnancies. In others, it was that there was no risk. So, for example, in the case of the de novo variants, and there were 6 relatives of the infants that we tested who went on to receive diagnoses based on our findings. So we thought that that was quite a good set of clinical outcomes from testing. Okay, so that's the first part. That's deafness. The second part is that we thought, well, here we're going to be seeing all of these infants, and we're going to be running exomes on all of them. And of course, when you run an exome, you get information on all of the genes, not just those 134 that are associated with deafness. And at the time we were setting up this project, there was quite a lot of literature along the lines of the future is that all infants are going to be have exomes or have genomic tests done at birth, and there was various editorials and opinions about that. And so we thought, well, here's an opportunity to see how that might work in practice. And at the time, most people who had published around that question had focused on sort of hypothetical questions. So if you go to parents and say, if you could have your baby genomically tested or exomed at birth, would you want to have that done? And a lot of that work had shown that people generally said, yes, we think that's a good idea. But I guess it's quite important to note that how someone responds in a hypothetical scenario may be quite different from how they respond when they're actually going to be faced with getting a result. So genomic testing of newborns or genomic screening of newborns raises a number of questions, including whether this is something where choices should be offered to parents as opposed to the way newborn screening currently works, which is basically one size fits all. Everyone gets the same thing. And I should say at the moment, although people can decline existing newborn screening, very few do. So it's sort of 99.7% uptake. How should parents be consented? And then some of the really tricky questions are, where do you start in terms of testing? Because essentially you're talking about screening a healthy newborn. What disorders should be included? what variants should be looked for, what information should be given back to parents. So when we designed this project, we decided that basically everyone who enrolled into the project would get testing for hearing loss. So we called this Choice A, testing just for those 134 deafness genes. But we offered our parents 2 additional choices. So the first of those we called Choice B, and this was, so all of these related to other genetic conditions, not deafness, that could present in childhood. And the first was Choice B, and conceptually you can think of this as being similar to disorders that are currently tested in newborn screening in terms of severity, evidence of therapeutic intervention. So this was conditions where there was an existing treatment or intervention that would improve child health. That was Choice B. And the third choice they could make was for Choice C. So this is disorders that had paediatric onset, but there was currently no intervention that would improve the health of the child. So giving this information to parents would not be expected to alter the natural history of the disorder in the child, but it would mean that parents would know in advance. They may avoid the so-called diagnostic odyssey, the difficult journey that parents often go through before their child is finally diagnosed with a rare disorder. And where there was a risk for future pregnancies or future children, they would have that reproductive risk information in advance. And it is one of the tragic things about working with genetics is when you see 2 parents who end up with more than one child affected by the same disorder because the diagnosis is not made until both children are born, where it could have otherwise been avoided. In terms of making decisions, we designed a decision aid. I should add, so we called this part of the project Baby Beyond Hearing, because it was beyond the hearing part of the exome analysis. And we designed a decision aid which was to help parents just come to a decision about which of those 3 options they wanted to choose. So before they had the appointment in the clinic, this was mailed to them so that they were, they'd done some homework essentially, thinking about what they wanted to do. So this is just an example of the types of questions that are in the decision aid. So they relate to questions like, do I want to have genetic testing for my child? You know, am I the sort of person that would want to do this? Am I the sort of person that wants to seek information or would prefer not to know information? So that's around the decision process. And then we got to this question of, you know, when we've got the whole exome as a starting point, how do we possibly decide which of those, say, 4,000 genes that comprise disorders that have been linked to a human disorder, which of those are we going to choose for analysis? And we were fortunate in this regard that we had some collaborators in the US, particularly at the top 2 places in North Carolina and in Boston, who had done a lot of this work, which is quite painstaking, for us, and so we were able to utilise their efforts. So the first, this is from a group in North Carolina, the NC Nexus group. So they set out several years ago with this NIH-funded project, which was quite ambitious, and they were really looking at trying to implement newborn screening in their clinical environment. And they basically developed this metric for scoring genes. So they put all of the genes through this metric and gave them a score based on parameters of the severity of the illness, the likelihood of symptoms ever developing, the efficacy and acceptability relates to treatment. So is there an effective treatment available? Is it something that is acceptable? And, you know, what is the current state of knowledge? So based on all of this, every gene that they looked at got an actionability score between 0 and 15. So this took a lot of people a lot of time. So if we'd had to replicate this, it would have slowed us down immensely. In fact, we probably would never have got to the end. And then they're able to put all of this information on this quite nice graph where on the y-axis you've got the actionability, so that's that score out of 15 that I just showed you. And then on the x-axis you've got the age of onset. And on this particular graph there's a few quite well recognised conditions, so familial adenomatous polyposis and Lynch syndrome, the two most common autosomal dominant bowel cancer syndromes. You can see that they are high up in the actionability score because they're at the top of the graph, and they have that sort of onset in teenage years through to adulthood. Whereas you've got disorders towards the bottom like Rett syndrome and early onset Alzheimer's disease where they score lower on the actionability scale because at the moment at least we don't have a whole lot we can do in terms of prevention of symptoms. And so if over the top of this you can you can put this sort of 2x2 table and, oops, hold on. And so the area we are interested in is that in the top left corner. So these are disorders that are early in onset, paediatric onset, and actionable. So you can kind of think of this as your choice B, and then all of this would be your choice B and C. And we decided to stay away from adult disorders. In fact, the North Carolina group, when they started on this journey, they were interested in offering testing for adult onset disorders as part of their newborn screening, but they kind of got bogged down in ethics requirements and so forth, probably for good reason, because this would be quite a controversial thing to offer predictive testing to newborns for adult onset disorders. So from all of that, we came up with our choice B list, which basically was the North Carolina's group minus deafness genes. So they had included some deafness genes in their list, which of course we didn't need to include because they were already in our choice B. And so, you can have a look through this and there might be one of your favourite genes in there. But, that it does include things like, I guess if you start at the beginning, APC for familial polyposis. It has things like cystic fibrosis. It's got some cardiac genes like long QT syndrome. For our choice C, so this is our disorders that are not treatable but paediatric in onset, we built on this system that was designed by Heidi Ream's group in Boston and published in Genetics in Medicine in 2017, as you can see. And I won't go into great detail about this, but essentially they looked at about, they looked at a very large number of genes and they categorised all of them in terms of evidence, age of onset, penetrance, and they ended up with a group of disorders, a group of genes, just under 1,000 genes, which they thought would be suitable for genomic newborn screening of infants. As an aside, for this project, which is the BabySeq project, which is still running, they have struggled with their recruitment. So when they have offered testing or they've tried to enrol families, they have found that the vast majority of families have declined being involved, and we can compare that with our recruitment when I get to it. So this was very helpful for us. However, we decided that we were not comfortable giving parents information about a diagnosis in a child that was essentially looked fine unless we had another methodology to confirm the diagnosis. So an example might be an intellectual disability gene. So if we found what we thought was a causative variant in an intellectual disability gene where there was no syndromic features, we thought it would be very difficult to give that information to parents of a newborn and then not have any other evidence that it was actually causative. So how confident would we be that the child, that this was a real bona fide finding and that the child would go on and develop intellectual disability? So when we designed our list C, we basically put in this extra component that there needed to be some method of validation, and that might be through biochemical testing or it might be through imaging or some other phenotypic assessment, but that was basically a safety net for us, I guess. Keeping in mind that we weren't really trying to make lots of diagnoses. This is really a proof of principle, looking particularly at how do parents respond when offered this type of testing. So this list had 222 genes. When we do analysis of exomes in patients without phenotype, we need to be a little bit careful about what we report. And essentially, so for our deafness genes, which is what we call indication-based analyses, we would be reporting pathogenic, likely pathogenic, and variants of uncertain significance. But for this sort of newborn screening component, we were only reporting pathogenic and likely pathogenic. And we also made the decision that we were not going to report carrier status for recessive disorders, keeping in mind that the majority of exomes have carrier status for at least one condition, and we just decided that that wasn't really a helpful piece of information to disclose to parents of a newborn. So probably the biggest question we had here was, what choices are parents going to make? Keep in mind that previously, when parents had been surveyed about whether they would like this type of testing, lots of them said yes. But we know from the experience with the BabySeq project in Boston that most parents said no, thank you. So what do we find in our cohort? Well, essentially, our parents were fairly evenly divided across the three groups. So about a third wanted only the deafness genes, about a third wanted choice B, that is deafness plus conditions that are treatable in childhood. But we still had 41% who wanted information about those disorders that have onset in childhood but are not treatable. So just a couple of case reports. So this is Henry, a 3-week-old infant, referred following failed hearing test, referred for this project. And what happened here was, and we actually had to go back and report this to the ethics committee, was these parents basically became paralysed with fear about having to make a choice. So they found it very hard to choose. Like, keep in mind, they'd already accepted being enrolled into the program. They knew they were going to get testing for deafness, but when we offered them the choice between A, B and C, they found that all too much for them. So they felt conflicted between, on the one hand, they felt they didn't really want to know this information, but on the other hand, they felt that they were doing their child a disservice by not having the testing. And this was really quite unexpected, at least for me, because I thought if people don't want to have the testing, they just won't come into the project. They would decline, at the first hurdle. But I think this is really interesting, an example where sometimes offering choice, which in genetics we're often all about, it's a good thing to offer choice and give people the autonomy to make choices. But in this example, in fact, providing choice seemed to have caused some harm. This is another case report. I should say that out of all the choice B and C analysis, we've only found 2 variants that we've ended up reporting back to the families. And this is one of them. This was an infant who was diagnosed with Pendred syndrome. That's the syndrome that has deafness and thyroid disease. This couple had opted for choice C, and we found a pathogenic variant in the gene MEFV, which is for familial Mediterranean fever. Now, this is a slightly tricky gene because usually it's a recessive disorder, so you might think, well, we wouldn't report it based on the fact that we had previously said we weren't reporting recessive findings. However, there are some examples in the literature of variants that have seemed to be working as an autosomal dominant in certain families, and this was one of those variants. So we provided that result back to the parents, but we really downplayed the significance of the result because we did not want to raise anxiety for something where we didn't think there was a really significant risk. And the parents were fine about that. And in fact, as I've noted at the bottom, they are now pursuing pre-implantation genetic diagnosis to avoid having a second child with Pendred syndrome. So we're still in the process of looking at our information regarding evaluating this whole process, and we've built a lot of this into the protocol, and I haven't got final results to show you today, but basically families were asked to fill in a survey after making their initial decision, which looked at things like their health literacy and their levels of anxiety and whether they perceived how they perceived their control to be in that circumstance. And we have about 2/3 have completed that survey. And then after receiving the final results, there's another survey which they're asked to fill out. And this is all trying to work out whether this is a process that is acceptable to them. In terms of how the process worked, so the decision aid that we provided families, most of our participants used it, most of them filled it out, and most of them found it useful. Most of them had made the decision about what they wanted prior to having their genetic counselling appointment, but a proportion ended up changing their mind after their genetic counselling appointment. So that suggests that both the decision aid and the genetic counselling appointment are important in their decision making. And yeah, so some changed their mind. That's just that point. One interesting finding, so we were recruiting from two main sites, one being at Monash and one being at RCH. And when it came to that, choices regarding additional findings, we found that there was a significantly higher rate of Monash patients chose to receive additional findings compared to RCH. And we're still trying to get our heads around that. But obviously, so there were different genetic counsellors working at the two locations, and you might imagine that these sort of decisions might be quite strongly influenced by how the information was presented in the counselling session. Of course, there may be demographic factors as well between the two populations that influence, but not quite ready for publication at that point, but I just thought that was an interesting comparison. In terms of the choices that people made, we asked them why they made their choices. Most people felt that the choice they made was the only right option for them. Most of them said they weighed up the pros and cons, and they found that it was the best option for their patients and family. This is an interesting one. How did they make their choice? Well, quite a few of them, these two, said they made their choice because they feared the other options. So that's basically saying they were scared of choice C. They were scared of finding out information about the health of their child that they couldn't do anything about. So that's a completely understandable fear. And fortunately, only 5% said they didn't understand what the other options were. So in terms of where we go from here, so we're still analysing all of that survey data. We're going to do some health economic analysis, which is now kind of standard if you're trying to get a clinical or a service translated into clinical practice. We're doing some more qualitative analysis, including interviews of families to try and work out how they valued the genomic diagnosis. And of course, we now have all of these deafness patients for which we have exome data, so we can go back and mine that data, both looking for new deafness genes, potentially looking for digenic or polygenic models, and that's something that's ongoing. So in summary, our exome sequencing has increased our rate of diagnosis from 21 to 56%. The early diagnosis has important consequences for families. The phenotypes that are associated with deafness are very broad. And we did find that patients in general were interested in getting additional findings for their infants. And so just to finish up, this is a work of a large number of people across Melbourne Genomics, the hearing associated clinicians, And I just want to particularly mention Lil Downey, who's been the PhD student who has done most of the day-to-day work and allowed me to sit back in the background and just give talks like this. So thanks to Lil and thank you.
Thanks, David. Doug.
Nice talk, Dave. A couple of questions. One, obviously the genetic diseases for which interventions can be made changes over time. So do you have an obligation if a patient has chosen option B, and in a year's time you now know that a disease that wasn't previously treatable is now treatable, do you move genes from C to B? Do you have any obligation to tell them?
Yeah, I mean, it's a good question. I mean, that's a question that comes up in clinical genetic analysis and analysis of exomes in general. And I guess, in principle, we would like to say, yes, we can go back and do all of this, but at a practical level, as the number of exomes that are processed goes up and up, it becomes a pretty difficult job. I would say for the patients that are in our cohort, which are a manageable number, we've had a few instances now where clinicians have come back and said, we're concerned about something, or our patient's got a certain presentation. Can you go back and look at that data? And we've been able to do that, but I guess that's really because we've got the manpower. I think if we go into the future, it just will not be practical to do that for all exomes.
And my second question is, you obviously focused on diseases that present when a person doesn't have the capacity to consent for themselves, so 18 or less. Is there an opportunity for those children to come back when they do turn 18 and say, thank you, you've done this research on me that was consented by my parents, I would now like information?
Yeah, so we certainly did not build that into the protocol. I mean, I'd like to think I'd still be around in 18 years' time and maybe we could run another project. Yeah, so the data will be there. I guess, in genomics, it's hard to see even a few years into the future rather than 18. And I mean, my gut feeling is that in 18 years' time, all of this stuff will be so commonplace that we won't be delving back into data from circa 2017.
But presumably that framework will still be the same. Everybody may have their data on their USB stick
yep.
or their credit card, but you're still going to be presented with the same dilemma, and that is, what should a parent be able to consent their child to know? So you're still going to be stuck with the dilemma. Is when as an 18-year-old. How do you consent for the next test?
Yeah, no. I mean,
it doesn't really matter how old the data is.
I agree. It's a really interesting question, and people have. I think the North Carolina group had considered building that into their protocol, but as I said, they got stuck really pretty early on in what they could get through their ethics committee, and we had to kind of pare back what we wanted to do as well, just to get through ethics under a research protocol.
I'm not sure if this would make sense, but I'm wondering if there's an option C type option in which parents wouldn't find out or would elect not to find out about a condition until symptoms presented themselves, so that they could be spared a diagnostic odyssey, but no information while they were sort of impotent.
Yeah, it's a good question. So 3 options was enough for us, and I guess if we were doing it again, we could add that option. I'm not quite sure whether parents would actually be able to get their head around what you're suggesting, and like how you'd present that option as one that was different to the others, but a valid one. I guess. All of our participants know that the data is there, and they know that there is the potential to analyse it because they've been educated about that. So whilst we haven't specifically said, oh, if your child gets some strange symptom, come back and we'll have another look, they may be able to join the dots and do that. And as I mentioned, we have had a couple of patients who have gone on to present with other more complex symptoms, and we've gone back and re-looked at the data.
So this goes back to one of the previous questions, but isn't the finding of a BRCA1 mutation or Lynch syndrome mutation, clearly you don't want the parents to make the decision, but isn't there an ethical problem if the children, once they are 18, don't get to know, because they could actually make decisions at that point that could be life-saving?
Yeah, so the question for those of you at the back is there a problem that we've sequenced these exomes in infants and one of them, unbeknown to us, might have something like a BRCA mutation, but yeah, which could save their lives, which they're never getting the benefit of that information. Is that right? Have I paraphrased that correctly? So yes, I mean that's a big issue. We don't see the BRCA mutation, right? So when we do the analysis, we are, blinkering ourselves to that. We specifically have a set of genes that we don't want to see in children, and we throw them out at the first part of the analysis because we're not comfortable knowing something like that and not sharing it with the family. I mean, if I knew that an infant had a BRCA mutation, I would want to tell the parents, not for the child's benefit right now, but because the mum might well have it as well. And you can certainly argue that it's in the best interest of a baby that the mother does not develop and die from breast cancer. So I agree with that argument. It's just ethically too complex to allow us to do the analysis at this point. I would quite like to do it at a research level, but we would not have got it through the ethics committee. They would have just said you're doing predictive testing on an infant who cannot consent for themselves.
I was wondering, in principle, is the patient, the parents, or the service, or someone else, the owner of the data? Therefore, if the patient has ownership of their own data, should that be part of my health record? So is this medical information that then resides in a way that can be accessible in the future for the patient?
So I'm neither expert at my health record nor the legalities of that, but I believe all of the data, it's the final result that goes out from the lab certainly would be part of my health record because it is a NATA accredited lab pathology result, and I think that is under the Health Records Act. As to the data that's generated, yeah, I'm not sure. Can't answer it.
You mentioned the copy number variants were detected by microarray. How have you used that data? Has it been useful? Have the exomes given you any copy number variant data that was duplicative? And how do you see whole genome data with the ability to use pick up copy number variation?
Yeah, so when we started this project, we weren't planning to do arrays, and then there was a bit of literature just as we were getting started suggesting that, in a single figure percentage of kids with deafness, copy number variant was important. And there's a gene called STRC where there's a recurrent deletion or copy number variation that we wanted specifically to target. And we found several cases of homozygous deletion of that. And then we found a couple of patients where there was a point mutation on the exome data on one allele and a deletion or copy number variant on the other. And that gave us our answer. So it was definitely worth doing. Our analysis pipelines are not quite up to speed in terms of copy number variation detection from the exome data. Certainly if we had genome data, we could have done it all on the one the one platform.
I was curious about the predicted value of the GG screen for in option B. So do you have a threshold? So I suppose it's a two-part question. The first part is do you have a threshold for the penetrance of disease progression with mutations? Are they all fully penetrant?
So we use that metric that I showed, the score out of 15, which included assessment of all of these factors. Now, those things are also somewhat arbitrary. Like if you ever sit down in a committee trying to decide how actionable findings are, you do get quite diverse opinions because it involves, quite complex mental gymnastics trying to piece together all the evidence. But we basically used that. Yes, they're not all the same. I mean, all actionable is not the same. We see that in existing newborn screening. You'd say something like PKU is really at the top of the list because you can change the diet and avert intellectual disability. Cystic fibrosis is a bit further down the list in terms of actionability. But, at the end of the day, we drew a line at the point where the North Carolina people had, which was like a score of 10 out of 15 on that actionability scale.
Let's all just thank David for a great
Thank you.